Hi, this is Dr. Levine, and welcome to my YouTube channel. And thank you so much for allowing me to take care of you. If you're watching this video, it means that you have an unstable or dislocating shoulder and you have decided to proceed with surgery. That means that you're no longer willing or able to live with the symptoms. It means you have failed non-operative management, including physical therapy, and that you would like to proceed with having me fix your torn labrum. If you have an anterior labral tear, which is the most common tear that we have in instability, the plan will be to arthroscopically fix that. That means on the day of surgery, you'll come in, you'll get an interscalene regional anesthesia block, which means we put your shoulder to sleep, but you don't have to have general anesthesia. We then put a camera or an arthroscope in your shoulder through 3 tiny incisions around the shoulder, and we fix the torn labrum back to the bone. The way I describe it is like a gasket around a pipe, and we're going to put the gasket back to the pipe, or in this case, the labrum back to the bone. We hold it in place with suture anchors, a series of small devices that are drilled into the bone of the glenoid or the socket with sutures attached to them. The sutures are passed around the torn labrum, and then we repair the labrum back to the bone. The minimum number of anchors we typically use is 3, but it can go all the way up to 12 anchors in the largest of tears. It's not uncommon for us to also perform an operation called a remplissage procedure. That's a French word that means to fill. And what we're filling is the defect on the humeral head. You remember that term Hill-Sachs deformity? That's a little indentation in the back part of the humeral head, similar to us putting our finger into a ping pong ball and causing a dent. That dent can be problematic, and so we're going to take the local tissue, the infraspinatus, that's one of the rotator cuff tendons, and its capsule, and we're going to actually place that into the defect and hold it in place with 2 additional anchors, as we discussed earlier. So the typical operation is called a anterior Bankart or labral repair and a remplissage procedure. You'll be in a sling for 2 weeks after the operation. We typically begin physical therapy after 2 weeks. At that first post-op visit at 2 weeks, we will discontinue the sling, make sure your wounds look good, give you a referral to start physical therapy, and if you feel comfortable, you can begin driving when you feel safe. You'll start that physical therapy program in the first 3 months. We call that phase 1. The goals are very simple. Get all of your range of motion back while your wounds are healing and while the labral repair is healing. We get to phase 2 from month 3 through month 6, and that's where we'll start working on strength and functional recovery. Your second post-operative visit will be with me at 4 months post-op, and at that visit, we'll expect you to have regained full range of motion because you'll be out of phase 1 and already beginning work about a month on strength in phase 2. So you'll be doing quite well overall. Remember, it can take up to 12 months for full recovery, but we will see how you're doing at 4 months and then usually schedule your next visit around 7 to 8 months post-op, depending upon the individual. So I hope this helps you to understand what's going to happen with your unstable shoulder. This is Dr. Levine. Appreciate you taking time to watch this video, and we look forward to giving you back a stable, normal, functional shoulder that no longer dislocates, causes pain, and causes you dysfunction. Thanks very much. Have a great day.